So welcome back, everybody, to the second session. Sorry, it was a very short break, but hopefully we've had quite an interesting and good discussion session in the first one. I'm sure the second one is going to be just as interesting. I'd like to invite our colleague, Dr. Ruth Corbally, who's GP and clinical lead for primary care clinical lead for cancer in Powys, and the Powys FIT team to present their perspective. In this session, we'll be hearing mainly about the experiences of the different health boards. And thank you very much, Ruth.
Hello, I'm Dr. Ruth Corbally, the clinical lead for cancer and the Macmillan GP Cancer Lead for Powys Teaching Health Board. And thank you to Mike Griffiths, who's helped me collate the information for the presentation today. So thank you for inviting us to take part in the event today and share our experiences in Powys. I've prepared a few slides to update you on our progress with symptomatic FIT testing so far. The Powys Teaching Health Board is unique. We have a population of 133,000 people spread over 2,000 square miles, which gives us a very low population density. And we've no district general hospital and no CT or MRI scanners within the health board, just to give you an idea of our background. The local services are provided mainly through primary care, community hospitals and other community services. And this does include a nurse-led endoscopy service. We're lucky to have experienced nurses in the team, but a lot of our endoscopy is still provided by our commissioned providers around our borders. And we also have an active voluntary sector committed to supporting our local population. So the vast majority of specialist care is provided by our surrounding health boards in Wales and across the border in England, mainly by Shrewsbury and Telford hospitals and the Wye Valley Trust, where we do have multiple providers. In fact, more of our patients with cancer are actually managed in England than in Wales, and we maintain positive collaborative relationships with our English providers, though there are still a lot of challenges with access to data cross-border. Cancer is one of the big 4 priorities in Powys's integrated health and care strategy, and the Powys Renewals Cancer Programme has identified establishing symptomatic FIT testing as a priority, as it aligns with several of our priorities, including earlier diagnosis of cancer, ensuring equitable access to diagnostics, and also provision closer to home where possible. We're pleased to have successfully established access to symptomatic FIT testing for all of our GP practices across Powys now, though the pathways vary geographically. Practices in the North Cluster and in Ustragan in the South are currently accessing symptomatic FIT testing directly through the Public Health Wales Laboratory. Practices across Mid-Powys have an established service provided by the Wye Valley Trust, where their patient flow goes as well. And then finally, Brecon, Crickhowell and Haygarth practices in the South Cluster access symptomatic FIT testing in the Public Health Wales Laboratory, but via Aneurin Bevan Health Board. And this has the advantage that any positive FIT results are directed onto the colorectal urgent suspected cancer pathway in ABHB without requiring action by the practice, hence streamlining the pathway for patients. So although we've established access across the health board now, we do expect the pathways to evolve as other services become available. The pathway into Aneurin Bevan Health Board and Wye Valley Trust will continue, though as these reflect the patient flows from these geographical areas. And the service level agreement with Public Health Wales for FIT services, which was initially agreed up to the end of March, has been continued. Shrewsbury and Telford hospitals are also establishing a FIT service. They'll revise their urgent suspected cancer colorectal pathway as well to incorporate the FIT testing once it is accessible in their trust. Initially, this was planned for this month, but has actually been postponed currently. And once this service is available in South, then we'll revise our pathway in North Powys to reflect patient flows for their ongoing management. Of note, in Wye Valley Trust, FIT test results are currently required as part of their USC referrals to their colorectal service. And while Shrewsbury and Telford are revising their colorectal USC pathway, they hadn't actually decided whether they would require the FIT test to be requested simultaneously to the referral, or if a FIT result will be required for the USC referral as yet. Discussion with both teams in Wye Valley Trust and SAF have confirmed, though, that GPs can refer patients meeting NICE criteria for USC colorectal referrals, even if their FIT test is negative, for secondary care to determine the level of their further investigation or management. So once we agreed access to FIT testing, the next step was to implement the FIT testing into practice across Powys. We discussed this with our cluster leads to explore their preferences for engaging primary care, and the consensus was for protected learning time educational sessions. So we secured funding to provide additional protected learning time sessions for all the practices across Powys. And traditionally, these PLT sessions are delivered in 2 groups. So we followed the same pattern and invited practices to opt in to take part in the sessions, with the offer that the health board would fund the out-of-hours primary care provider to cover the practices to close for the afternoon, as they do for the usual PLT sessions. So this allows all the staff in the practice to attend the session. And we designed the afternoons to maximise the educational opportunity to share cancer-related topics with primary care, and also to try and make them worthwhile for the practices to opt in to attend. And separate sessions were organised for clinical and non-clinical staff to keep the learning appropriate. The clinical sessions covered symptomatic FIT testing and also rapid diagnostic centres, as that's one of our other priorities currently. It included the Improving the Cancer Journey, who have pilots offering holistic needs assessments to people living with cancer in the community in Powys, and a general update covering a variety of cancer-related topics that we felt would be valuable to share with primary care, such as the cytosponge, transnasal endoscopy, and the concept of rehabilitation to rehabilitation services. We provided learning to encourage non-clinical staff to support patients with cancer as well. There was a valuable opportunity to share the Cancer Buddy training, which was developed by the fantastic nursing team with the Macmillan Primary Care Cancer Framework, and we used videos of training that they had previously delivered. We also had short sessions to raise awareness of the Improving Cancer Journey, holistic needs assessment pilots, and our third sector partners for the non-clinical staff. We were very pleased with the uptake. All 7 practices in the north opted to take part, and 8 of the 9 practices in Mid and South Powys opted in as well. Practice which didn't opt in had limited staff in practice the day of the proposed PLT, so they didn't feel that it would be valuable to them. So we're sharing the learning with them now. And overall, we had 347 primary care staff attend the educational sessions, 149 of these being clinical, and so taking part in the session on the symptomatic FIT testing itself. And these are big numbers for Powys. We requested feedback from the participants using the standard evaluation forms used by the primary care education teams for the PLT sessions. And the feedback was very positive overall. I've included the scores for the FIT presentations, as you can see on the slide. Those scores were all out of a maximum of 5, and the averages for each PLT session ranged from 4.2 to 4.6 for the presentation, its content, and educational value. Some of the comments were specific to FIT testing and included feedback from GPs and practice nurses as well. You can read the individual comments on the slide. They showed appreciation of the information about the FIT test itself, in particular the difference between positive results for screening and symptomatic FIT testing, and also pathway referral advice. We really wanted to raise awareness and understanding of FIT testing to encourage engagement from primary care, but also to highlight the pathway to encourage appropriate use of the service. And we were very fortunate to have wonderful support from our colleagues in secondary care in providing the learning for the sessions. So moving forwards, we now want to ensure that FIT testing is embedded into routine practice, and for this we'll need data on who is using the test at practice level. A cancer services tracker has joined the cancer renewals team in the health board, and she's successfully established connections with all of our providers and is obtaining more data for Powys patients. However, data collection on patients in Powys is still very challenging. We are developing a Power business intelligence tool to follow live data for our patients on cancer pathways. However, with regard to symptomatic FIT testing, this will only identify patients on USC pathways, so will only include those patients with positive FIT tests who go on to the cancer pathways. We're very reliant on receiving data from our commissioned service providers. We've requested the information on the number of FIT tests which have been requested so far, along with numbers of positive and negative tests identifiable to practice level, but we didn't have this data up to the end of last week when I prepared the presentation, so I apologise for not having figures to share with you. So it does highlight the fact that we do rely on our commission service providers to enable us to get this data. And this data will be valuable for establishing the engagement of different practices with symptomatic FIT testing, which will enable us to support practices who are slower to take it up. The template for collecting data on symptomatic FIT testing, which was shared, is very comprehensive, and we can see how this information will be valuable for assessing its use. Data is crucial to support the value-based healthcare, which underpins the principles of our renewal programme to do what matters and to do what works. However, we would find it challenging to access this level of data in Powys, both due to the accessibility of the data, but also our team capacity, as we are a small team here in Powys. But we look forward to accessing more data to assess symptomatic FIT testing in our population and also seeing the outcomes on a national level as well. So thank you.
Thank you, Ruth. That was really excellent. And I can see two areas where it's really commendable how much you've had a head start is the amount of effort put into GP education and training and understanding how important business intelligence is. We'll have If I may now introduce our next speaker, Mr. Mike Thornton, who's consultant colorectal surgeon in Betsi Cadwaladr Health Board and very engaged and an early adopter of FIT. And Mike is going to give us a perspective from secondary care in North Wales. Thanks, Mike.
Very much, Sunil, and thanks for the opportunity to talk about our experience of using FIT in the colorectal pathway in North Wales. If you just have the first slide, please. So prior to 2020 and the COVID pandemic, we had no experience in this health board of FIT, and we weren't one of the FIT pilot locations. However, given the impact on our diagnostic services when the COVID pandemic struck, we had to create some plans with some haste in response to that on a background of an existing hugely pressured service with long waiting lists. Primary and secondary care FIT pathways were developed and with a lot of engagement from interested local primary care representatives, and primary care were also represented on our local clinical CAG panel. I drafted these pathways based on the evidence available at the time and after consultation with colleagues such as Craig Martin, Ninewells in Scotland, who has huge experience, and also some discussions with Nigel D'Souza and Muti Abalafi of the Nice Fit study group, who were also very helpful in allowing me to adopt a fairly pragmatic yet evidence-based approach to drawing up these pathways. We also initially used FIT to revalidate our existing endoscopy waiting list in the context of a significant reduction in the capacity and to try and help with the waiting lists. Next slide, please. So this is our primary care clinical pathway that we drew up for GPs to follow. And this was in use since June 2020 and has not undergone any significant modification in that time, as it seems to have been adopted reasonably well with good feedback. However, we would, as we've already discussed, like to move towards FIT being used essentially for all comers now, including those with rectal bleeding. Originally, we left this to some discretion of the referring GP. But I think this pathway makes a particular emphasis on ensuring that blood tests have also been checked to assess for iron deficiency anemia. The carrot on the stick being that even in a FIT negative patient, a patient with iron deficiency anemia will get fast tracked for referral. Initially, we were trying to reassure our primary care colleagues that if a FIT hadn't been performed at the time of referral, the referral would not be rejected solely on that basis if the patient had high-risk symptoms. And we've pretty much stuck with that, actually. We do, however, return referrals if this pathway has not been followed. So if patients have neither had an examination or up-to-date blood tests or had the FIT test requested as per the pathway, then we will return the referral with an advisory note to the GP asking them to re-refer according to the pathway. And I guess somewhat ironically, that often tends to lead to quicker investigations for the patient, who can then be fast-tracked straight to test once we have all the available information. We will, however, allow referral on a 2-week wait pathway, providing that the FIT has been performed and blood tests being performed without them needing to wait for the result of that investigation. Next slide, please. This is just an example of the pathway that we used early on in the pandemic to help us deal with patients who were already waiting for colonoscopies, so they were already in the system, or in whom patients who'd undergone a CT during the time when we had no access to either CT colon or endoscopy. So there's 2 groups of patients we needed to have a strategy to deal with. And we utilised FIT again fairly pragmatically. So patients on the colonoscopy waiting list who were high risk after revalidation remained on the pathway for a USC colonoscopy. The lower risk symptoms, though, we arranged for those patients to be sent an information letter, and FIT was requested, and then further management was guided by that FIT result with safety netting. And similarly, patients who'd undergone a CT and we were presented back in our office with the CT result in a patient who we might normally have referred for an endoscopy, we were able to further assess that patient utilising FIT and decide on what the next steps ought to be. And I think that led to a fairly safe approach. We have not so far had any patients 2 years down the line who've come back with missed cancers from that pathway. This was only in use very temporarily early on, just for us to deal with those patients already in the system, but it did prove quite effective. Next slide, please. This is just a limited amount of audit data I've managed to obtain, just looking at the impact of our colonoscopy waiting list for the non-urgent suspected cancer patients when we arranged for them to undergo a FIT test. So after clinical review and a FIT, nearly 60% of non-cancer referred colonoscopies were actually removed from the waiting list and safety netted with advice to the GP, or they were reviewed back in the outpatient clinic. And that released valuable capacity to allow us to focus on the urgent suspected cancers and the FIT positive patients. Thanks. Next slide, please. This slide essentially represents what we've been doing in secondary care when we have the FIT result to hand. So we've attempted to direct straight to test FIT positive patients who are below the age of 75, providing that they've had an examination, and that's detailed on the referral. So it's important they've had an abdominal and a rectal examination. If that hasn't been performed, then often we will arrange for the patient to come to clinic first so that they can be assessed to make sure that they're suitable for a colonoscopy. What we try and do is reassure primary care that all patients referred on a USC pathway, regardless of the FIT result, so even if FIT negative, will get a clinical review. And even if they're FIT negative, if there are symptoms of concern, they'll often receive either cross-sectional imaging on an urgent pathway, or if there's lower concern, they may still get endoscopic assessment, but perhaps on a non-urgent pathway. It's you know, I think that's very important for both primary and secondary care clinicians to understand that a FIT negative result doesn't mean that the patient can't have a colonoscopy or a CT colon. It just means that they may not necessarily get that on the 2-week pathway, unless of course they have iron deficiency anemia, or if they have a palpable mass. CT, as I said, often occur in many cases, particularly if they have pain or weight loss. And it's important to remember that CT itself has a reasonable sensitivity of about 70 to 80% for colorectal cancer. Next slide, please. Just wanted to demonstrate how we're currently doing in terms of our FIT referrals. David Evans in Public Health Wales kindly recently sent me a huge data dump of a spreadsheet with our referrals, and I was able just to put this slide together. And I think this demonstrates very good utilisation in primary care and secondary care, and we're running at about 2,000 referrals a month via Public Health Wales. It's quite interesting to note that that's fairly consistent, and personally, having looked at this data a few days ago, I'm interested to see that there's about 350 to 400 referrals still going from secondary care, and we might need to look at that a bit further, because we really are trying to make sure that FIT is a primary care investigation. I do strongly see that as where that place is. I think that it's quite possible that areas in west and central of our health board may have slightly less compliance in primary care with the pathway, with FIT often not available at the time of triage. And I think that that's leading often some of the consultants in secondary care to do the FIT requesting on behalf of the GPs there. But we need to look at that a bit further. But it's encouraging utilisation. Next slide, please. My primary care colleague and GP in Corwin, Dr. Jenny Little, has been involved in the FIT work right from the start and kindly arranged a very brief snapshot audit of some views from primary care recently, which are demonstrated on this slide here. And again, I think this shows that FIT is being utilised a lot in primary care. The vast majority are requesting FIT according to the pathway that we developed. I am quite interested to note that about 20% of GPs are using FIT outside of our pathway for non-specific low risk but not no risk symptoms, such as tired all the time or non-iron deficient anemia. And that's a difficult area, and I hope that some of the forthcoming BSG guidance may address some of those issues. But it's reassuring to also see that GPs are finding often that their referral priority is affected by the FIT result, and they may be requesting referrals urgently on patients who otherwise they may not have done. And that's I think one of the very positive points of FIT. Next slide, please. In BC, our secondary care safety netting principles are essentially aligned with some of those we've already discussed. So we assess all 2-week wait referrals regardless of the FIT result. The patients must have had an examination at some point along the pathway. This is really important because we know from the large cohorts that have been studied so far that a number of the FIT negative cancers were identified in patients who had a palpable tumour on rectal examination. So whether that's done in primary care ideally or secondary care in a clinic, although that means we can't straight test the patient, it's important that at some point someone's put their finger in. As I said, we might utilise non-invasive investigations in patients who are FIT negative and also patients who are iron deficient. We are arranging investigations as per the BSG guidance, regardless of the FIT result. And patients who are FIT negative can still have a colonoscopy. Some of the challenges we faced is that, if anything, FIT may have been too much of a success. We've had quite a lot of engagement in primary care. We've done some educational webinars, which I've delivered. There was a lot of publicity, both in the traditional media, on social media, emails, and we found that we are starting to see a little creep in the use of FIT outside of the guidance for these non-specific symptoms. So essentially FIT being done as a screening test, and that makes the interpretation when we're triaging referrals quite challenging when we have a patient with no lower GI symptoms but modestly elevated FIT, it's very difficult to know how to manage that. If that had been done on the screening programme, those patients wouldn't have been recalled until 2 years' time. We're sometimes seeing referrals with positive FIT for very short self-limiting symptoms, for example, acute onset diarrhea. FIT sometimes being done as a first-line test when other investigations such as a stool culture may have been more appropriate. And so we're sometimes feeding back to say, hold on, you might have jumped the gun a bit here, please could you exclude, common causes of acute diarrhea. We don't really want acute diarrhea being referred into a surgical clinic. And particularly in Wrexham, and I know on the other sites, we've had a significant lack of any administrative support. I'm very interested in the idea of FIT teams, which I've seen on the presenters' details today. We certainly don't have a FIT team in Wrexham. It's very much down at individuals really, but we are trying to stick to the pathways. That means we've got very little sort of data to go on to judge the impact of the introduction of FIT in terms of its impact on our endoscopy waiting list, for example. A lot of the GPs have worked really well with us and following our pathway really well. We do have a lot of practices that are manned largely by locum GPs who aren't familiar with the pathway, so we do still get quite a lot of referrals outside of the coming in without FIT and examination, for example, and an occasional pushback from GPs saying that, well, the use of FIT isn't within the NICE guidance and you need to see them anyway, so I'm not going to do it, although that's quite rare. Certainly, we found the absence of FIT at the time of the referral is causing some delay in progressing that patient on the pathway. We have to wait until the FIT's available and get them into clinic, so it's occasionally causing several weeks delay if the FIT hasn't been requested or isn't available when we receive the referral. That's why I'd quite like in the future to see us having the FIT result documented on the referrals. We're not quite there yet. And we don't currently have any strategy perhaps for prioritising according to what the FIT result is. At the moment, anyone above 10 gets a USC, and I think occasionally, some of these, are lower risk, and we're utilising resources that, maybe traditionally we wouldn't have done. I know that some NHS trusts in England are starting to break down by the level of FIT, for example, less than 50 or less than 100, having perhaps lower priority investigations in certain cases, but we don't have any evidence base to do that at the moment. I think that's all I wanted to say. I've just about used up all my time as well, so thanks very much, Sunil.
Thank you, Mike. That's very interesting. There are a few things to discuss. I think that we should pick up in the panel discussion around use of subthresholds and rectal examinations, both quite important, but we're running a bit over time, so I think we'll save that for the panel discussion if that's okay. I think we'll save that for the panel discussion if that's okay. I'd like to introduce the next speaker, and this is the first in the next two talks. Our labs are the real centerpiece of why we've managed to achieve whatever we have, and they've been absolutely superb at helping us. And this first presentation is from the Bowel Screening Wales lab with David Evans, who's the Symptomatic FIT coordinator there. Thanks, David.
I'm David Evans, the Symptomatic FIT coordinator based in the laboratory here in Magden Park, Llantrisant. This is a presentation just to take you through the referral and testing process that we follow and some of the data surrounding this. For the Symptomatic FIT service, we require clinicians to use the online referral form accessed using the links on screen, the second link specifically for the enhanced card from Vale pilot only. When it comes to distribution, we once a referral is submitted, the data is stored online. The referral data is then downloaded on a daily basis, Monday through Friday at 10 AM and 2 PM, and exported onto a spreadsheet. To ensure the reliability, we assign a collection picker to each patient using the unique barcode on the picker itself. We combine the picker with a letter addressed to the patient, an instruction sheet, and the return envelope. Collection is done daily at 4 PM and always sent first class via Royal Mail. Once the patient completes the test at home, they send it back to the laboratory using the prepaid envelope. The sample is logged as received on the laboratory system LIMS and is tested immediately. Once authorised, results are automatically transferred from LIMS onto the Welsh Clinical Portal or GP link. We update an internal tracking spreadsheet containing key intervals on a weekly basis, and we provide this as an update to 2 health boards on a weekly basis and 1 health board on a monthly basis as well. With regards to workload, overall, we have seen a steady increase in demand for the Symptomatic FIT service. This demand peaked in March with 3,701 referrals, and we expect to regularly see upwards of 3,500 referrals going forward per month. From July 2020 to October 2021, we've been working with 3 health boards. Then in November 2021, 2 more health boards began using this laboratory for Symptomatic FIT. The data shown is for both primary and secondary care. However, Aneurin Bevan here and going forward represents secondary care data only, as we do not distribute the primary care referrals. When separated into primary and secondary care, we can see a definite increase in the uptake of Symptomatic FIT usage in primary care. Secondary care does show variation, spikes in demand appearing perhaps where COVID was prevalent and FIT was used as a triaging tool. As mentioned previously, Aneurin Bevan follows a slightly different pathway to the standard one used by ourselves. Whereby the kit is given to the patient directly by the GP. The sample is then sent to Biochemistry, where it is logged on LIMS as received, and then after that the samples are sent on to ourselves in Magdalen Park for testing. As a result, we do see a slight delay in the time from sample reception to result authorization, 1.8 days compared to 0.1 days for our standard pathway. The graph on the right does show an increase in the samples received. We can assume this is proportionate to the number of kits given out and can conclude that Aneurin Bevan primary care has also seen an increase in demand for Symptomatic FIT. From the key intervals that we do track, we are able to work out the total turnaround times from referral to result. On average, referral to result takes 9 days, and to expand, once a referral is submitted, it is always distributed within 24 hours, the exception being over the weekend. And then once the sample is received, it is tested and the results are authorised on the same day. Therefore, it appears that the longest part of the pathway is the time that the kit is with the patient waiting to be completed, and that's around 5 days. We do see trends in turnaround time at certain times of the year. During the summer, we do see spikes, presumably as people go on holiday and either put off or forget to complete their test. As well as that, during the Christmas period, we see definite spikes, likely due to the increased pressure on the postal service. From the kits that are distributed by ourselves, we see an average return rate of 84%. We therefore receive around 2,500 samples back per month. As well as this, we receive around 700 from the Aneurin Bevan primary care pathway. The return rate has remained fairly consistent as the pathway has gotten older and the number of referrals has increased as well. The average positivity across the health boards is 19%. This does vary slightly between months, more so in health boards which deal with a smaller throughput. It is worth pointing out that Aneurin Bevan has a positivity rate of 22%, which is higher than the combined average, but can be attributed to secondary care data only. Once again, breaking down by primary and secondary care. For primary care, we see an average positivity rate of 19%, whereas in secondary care, we see an average positivity rate of 21%. Both remain consistent as referral numbers have increased. We also track rejection rates. The average rejection rate is 2% across the health boards. The most common cause of this is the kit being sent back, but instead of using the picker provided, the sample is simply deposited into the bag the picker comes in. This is followed by patients simply just not completing the details on the kits that are sent back. The challenges surrounding symptomatic FIT from our point of view mainly come down to the referral form, the post and tracking it, and the non-responders. The referral form itself is manual entry only, meaning it can't be linked to a national database, and it is time consuming to complete and can often lead to human error when filling in the patient demographics. Because it's not linked to a national database, there is no information on the patient or test status, meaning that often multiple tests can be requested unnecessarily for the same patient. There is also no ability for us to send a completion confirmation, so there's no audit trail or reassurance for clinicians. Going forward, we would like to address this by moving towards an electronic requesting system on a system such as the Welsh Clinical Portal, which would largely receive these issues, amongst other minor ones. We are currently in discussion with the HCW about this functionality, but unfortunately we can't provide a time frame for when we will be ready to make this transition just yet. As touched on previously, common issues encountered with the post involve delayed or lost post around the Christmas period. This fact we're unable to resolve. However, we also see issues with tracking the kit once it has left the lab, as we're not able to track it until it's received back into the lab. Whilst a lot of this is out of our control, it may be possible to address this by actively prompting the patients with outstanding kits, which brings me on to our next challenge we face. Each month we see around 600 referrals with no response, 400 referrals returned over 2 weeks, and 1,300 referrals returned between 7 and 14 days. This is increasing as the service grows. Currently, the responsibility for these patients lies with the health boards to monitor and chase up. However, we are looking into the costing surrounding text and/or letter reminders to prompt these late responders. The change that we've already made to the pathways include a twice daily download. Originally, referrals were downloaded at 10 AM only. By incorporating another download at 2 PM, about 50 to 70 additional kits are able to be sent out on the same day as referred. This has led to a reduction in the average time from referred to actioned from 1.1 days to 0.69 days. In addition, we also now automatically send another kit to a patient if rejected by the lab. Previously, we found that 76% of kits were being re-referred, taking on average 16 days to be re-referred. Now, every reject is redistributed within 24 hours. Feedback from health boards highlighted that the service could sometimes be used inappropriately, and also that unnecessary duplicates were common. With regards to the duplicate requests, unfortunately, we've not been able to address this so far, but we did decide to add a NG12/DG30 option to the referral form itself. This is in an attempt to force referrers to reassess whether the patient matches the criteria of the service. Whilst the outcome of this needs to be confirmed, it has allowed us to see a relationship between DG30 and NG12 positive and negativity rates. For the data that we have since the option was introduced, we can see that there is a higher positivity rate among NG12 referrals and a higher negativity rate among DG30 referrals. That's all from me. Thank you very much.
Thank you, David. And that was really very key. Some really important questions there around how we track sample non-receipt. In the interest of time, if we move on, I'd like to invite our next speaker, Professor John Geen, consultant clinical biochemist with a huge amount of experience in setting up FIT in Cumtaf Health Board and also helping surrounding health boards with this. And John, very keen to hear your experience. Thank you.
Afternoon all. thank you for inviting me to this event and to give a presentation on the laboratory perspective of actually setting up a FIT analytical service within a clinical biochemistry service at Morgannwg University Health Board. So when setting up the service, it was important that we set ourselves some objectives that could deliver the service that we wanted. And the key objectives were, in my view, that it had to be clinically led and had to be undertaken for the right reasons. And top of those reasons would be we were seeking to improve the care for our patients and meet the needs of our local population, particularly in Morgannwg, where the survival rates, particularly at 5 years, for colorectal cancer was less than the UK national rate. So it was obviously an area that needed improvement, and this was one potential mechanism whereby we could seek to improve the care of our patients, working collaboratively. In addition, we were very keen to deliver the national guidelines, particularly NICE NG12, NICE DG32, and subsequently some guidelines that were published by some joint bodies in response to the COVID pandemic, and I'll come on to that later. We're also very keen to make sure the quality of the services was of the highest quality. From a laboratory perspective, I had to make sure that we were running a UCAS accredited service, because this is a requirement of Welsh Government that all laboratories should be accredited for their assays and service provision. It had to be clinically safe, had to be effective, and it should be evidence-based on whatever service we were delivering. It had to be patient-focused. We were very keen to optimise the uptake by the population within Morgannwg. And it was very important that there was a co-productive, collaborative partnership working approach with all stakeholders involved. And when you think about the stakeholders, in my view, that would cover patients, third sector, multi-professional, multidisciplinary clinical teams. Industry had a role to play. And in our particular case, Bevan Commission were helpful in the very beginning. It's important as well to ensure, as a key objective, that we could provide education and communication to the clinical service users, and to hopefully optimise the utilisation of the FIT service, particularly in primary care. We were also keen that the service would likely evolve, and to help the evolution of the service, it was important to ensure that we could develop metrics and undertake an ongoing review of the uptake, the clinical effectiveness of the service, and with a view to implementing improvements in the service as required. And from a research perspective, I was really keen, and I think everybody is keen, to ensure that we can develop and support research and evaluation projects by utilising a service that was going to be developed. So once we'd set the objectives, we kind of progressed the idea to develop a FIT service at Morgannwg University Health Board. And what helped us initially was we became aware of the Bevan Commission exemplar projects, and we thought it would be a really good idea if we could submit an application and try and obtain some funding to help us with perhaps developing a pilot study of our own within Morgannwg for FIT testing. So with this in mind, we were successful with our application, and we used the funding to help us design the patient information sheets and the GP information sheets particularly, and the request forms, but in collaboration and taking a co-production approach with patients and third sectors such as Macmillan and our primary care colleagues to design these information sheets to make them easily understandable by all concerned, and that they would hopefully encourage people to participate in a service should we be fortunate enough to establish one. But soon after we'd got the funding from the Bevan exemplar, we began working with Aneurin and Bevan as well, who were a little bit more advanced in terms of trying to develop a pilot study for FIT testing. And we had the analyzer, which we also funded in part from the Bevan exemplar funding. And we provided the analytical services for the Aneurin and Bevan primary care FIT pilot project, which is very pleasing. And it was great to work with work collaboratively with our Aneurin and Bevan colleagues, both in primary care and within the laboratories. Just after that, the COVID struck in 2020, and there was also new guidelines issued in April 2020 from the prestigious bodies, mainly gastroenterological and surgical bodies, providing some guidelines on how patients could possibly be triaged during the COVID pandemic with use of FIT. And we used those guidelines as a catapult to establish a full FIT service, at least within the secondary care service, for endoscopy triage. And that allowed us to evolve our own pilot work and mature it. The instrument we decided that we had been using was the HM-JAC ARC, and we used that for the Aneurin and Bevan work, and we maintained that instrument for our own work during the COVID pandemic to help with the endoscopy lists. Now, as I've already mentioned, it was important that we maintain or meet some quality standards, particularly within the laboratory, and we submitted an application for an extension to scope in our analytical services in November 2018 with UCAS accreditation services, and they granted us accreditation for the FIT testing service subsequently. At this point as well, there's a lot of discussion happening nationally, as well as locally and regionally, with a multidisciplinary and multi-professional team working together to try and develop a symptomatic FIT pathway. And this later became the National Endoscopy Programme. And the people around the table at the time that were helping to develop symptomatic FIT testing pathways was excellent, and the input from laboratories, gastroenterologists, endoscopists, surgeons was excellent, and it really did help shape the early version of a FIT testing pathway and endoscopy referral pathway within Cumtarth Morgannwg. In June 2020, we established a primary care pilot study within Cumtarth Morgannwg, and that was to test the whole process that we'd come up with and developed, including the documentation, and as well as how to request and how we would report the results from a FIT test. And then in July 2021, we undertook the full rollout to all GP practices, because the pilot study had limited access for just a few GPs for us to test the concept. Now, since 2021, we've been monitoring our service continuously and taking feedback on board from primary care colleagues, gastroenterologists and endoscopists, and our surgical colleagues to fine-tune the pathway that we've actually developed within Cumtarth Morgannwg, principally based on NEP guidelines and their framework, the NEP framework. And we're currently in the middle of just redesigning our pathway to iron out some of the minor issues that have come to light since we established the full rollout in July 2021. It's also important to note now as well that the Cumtarth Morgannwg FIT service is meeting one of our other objectives, and that was to support research. And we currently provide the analytical services for the nationwide CRAFT study being undertaken by Professor Harris at Swansea Bay and Swansea University, and that's also rewarding for the team. So I think that so far we service, and we're meeting most of our objectives that we feel we're meeting most of our objectives. This is the workload to date in the last 9 months or so within Cwmtaf Morgannwg. So these are just FIT samples that are actually analysed. 100, well, almost 1,800 in total. We also provide analytical services for Hywel Dda and for Swansea Bay, and obviously for this, the Swansea University craft study. So these are just figures for Cwmtaf Morgannwg UHB FIT requests. And our positivity rate at the moment is about 17.5%, which is about standard. As part of the study, I think it's important for us to think about the learned experience. And there are some key features that I've definitely learned from, and I think others may have learned from as well. And that is that co-production of the patient and GP facing information has been essential. Having their input is reassuring that the information we're sending out is understandable and it's written in clear English, and also subsequently translated into Welsh as well, which we've also undertaken. Partnership working with all specialties to make sure that any service provided is robust and safe, including the development of safety netting, is critical. And working with clinical colleagues in other specialties, and that's physicians, surgeons, nurses, managers. It's been a really positive experience, in my view, from the laboratory's perspective. We have developed metrics. There's metrics being developed nationally, and it's good that some of the metrics are national, because that can ensure that any other services that are providing FIT testing, we can measure each other and benchmark against each other in terms of the metrics that we're using to measure particularly the quality of the service provision, but also it's important that we can understand the clinical impact at a local and national level post the introduction of a FIT testing service with our endoscopy units and their roles in trying to diagnose colorectal cancers and perhaps other pathologies. So through ongoing monitoring of the service performance, we think that this will definitely identify any variations in uptake across the health board, perhaps across Wales as well, because that's important. We can target the areas where there's reduced uptake. It's important for us to identify the number and causes of rejected samples, the number of sample kits not returned within 14 days, and also the number and also investigation into sample kits that are never returned. We need to understand why patients don't return their kits, because we can address those concerns and hopefully improve the uptake from our patient population. And all this will help inform any remedial actions that we need to undertake to improve and optimize the service. And I also think there's a lot of shared learning going on, and through the NEP and also talking to bowel screening. And I'm particularly keen to await any data that's going to be generated by Cardiff and Vale Health Board on the use of predictor scores in addition to using FIT testing. I think there's area for further work. I think we need to establish if there is evidence to support the use of predictor scores, perhaps for triaging patients, but also, could they be used to improve the clinical sensitivity and specificity for detecting colorectal cancers? Should patients with overt PR bleeding undergo FIT testing? I think there may be potential to investigate other potential diagnostic and investigative uses of FIT testing. It's important to understand the causes of elevated fecal hemoglobin in the absence of pathology, which is recently just been published in the literature. And I think there's an argument these days to engage in if there's any development of an international standardization program for fecal immunotesting, for the quantitative analysis of fecal hemoglobin in feces, such as they've done with diabetes and HbA1c. I think that could be very useful, because at the moment there seems to be a slight difference in sensitivities and the levels measured by different manufacturers' assays. So I'd just like to thank and acknowledge the considerable contribution from all the multidisciplinary and multi-professional teams that have been involved across primary care and secondary care at a national and a local level. It's been great working with all the different specialties. It's been really good working with industry partners and the National Endoscopy Programme, patients and the third sector. They've all helped develop the FIT service across CTM UHB. And I'd also like to thank the laboratory team who undertake the FIT analysis and data collection and the data analysis. They put in place the safety netting procedures just to make sure that the service we provide is of the highest quality and it's safe. And to this end, I'd just like to congratulate them on winning last year's MediWells Award in partnership with the NHS Award with Alpha Laboratories. It states clinical biochemistry service on the award, but I just want to emphasise that the development of the end-to-end FIT testing stroke endoscopy referral pathway within Morgannwg has definitely been multi-specialty, and we've all played a role in progressing that service. Thank you.
Thank you, John. Very interesting overview of how the whole process started, and very interesting to hear about the really good work that's been going on in your lab. Adopters of FIT in Wales, from colleagues from Aneurin and Bevan Health Board, led by Dr. Mary Craig, Macmillan Primary Care Clinical Lead, Dr. Kath Bailey, Consultant Clinical Biochemist, and we're really interested to hear on your experience as well. Thank you.
Thank you very much. So this is going to be a little bit of a three-part act this afternoon, telling you about our experience of being one of the early adopters of Symptomatic FIT in Wales. So if we move on to the next slide. So it was back in 2018 that Mary approached the laboratory, really keen and enthusiastic to get a symptomatic FIT pathway up and running, and this was at the same time that national discussions were starting to take place. And really, we were in quite a fortunate position that we were able to secure some money, and we had really good clinical engagement. So in July 2019, we were able to launch the Aneurin Bevan FIT symptomatic pathway. Now, the pathway that we use for primary care, as you've heard many times this afternoon, is slightly different to the pathway that's used in other health boards across Wales. And the reason for this is obviously when we were trying to set it up back in 2019, the situation was slightly different, and availability of assays and availability of testing labs was different. So we had to come up with an alternative way of doing things. And so after consultation with lots of primary care colleagues, we came up with a pathway which involved the FIT kits being issued by the GPs directly to the patient, and then those being referred back through the laboratories in Aneurin Bevan, initially to Cwmtaf and then subsequently to Magdalen Park. And as part of that pathway, when a positive result was generated by either Cwmtaf or Magdalen Park, a referral to the straight to test pathway was made by the Aneurin Bevan laboratory team, and this meant that once the GP had given the patient the kit, then they were assured that actually a referral would be instigated if it was necessary, based on the FIT result. Can we have the next slide, please? And one of the reasons we were able to do this is that we had a very comprehensive FIT request form, which we are still using now. And within that FIT request form, there's lots of information on the patient history, there's information on medication, on performance status, and on their physical and clinical presentation. And that form is really useful to the nurses who perform the telephone assessment of the patients with the positive results, and it forms the basis of the referral into secondary care. I think at this point it's useful to say this process is quite labour intensive, and we've heard lots about FIT coordinators this afternoon, and without a FIT coordinator in the laboratory in Aneurin Bevan, this pathway would fall apart. So that for us, that's been a really key, she's been a really key person in delivery of the pathway. So if we move on to the next slide. Yeah, so this graph just shows our some sort of headline stats since the start of the programme in July 2019 up until the end of January this year. You'll see the bars on the bar chart. The paler green are the number of kits that have been issued to primary care, and the darker green are the number of kits that are sent back in for testing. So up until January 2022, we'd sent out approximately 14,000 kits to primary care, and of those, 12,000 have been returned back to the lab for testing. Of those 12,000, we've had we initially started in the first sort of 6 months or so of the pilot, our positivity rate was about 12%. And then from January 2020, this increased, and positivity rate now has settled at somewhere around 19 to 20%, which is in line with figures that other people have presented this afternoon. And then in terms of our spoil rate, so these are kits that are either returned with incomplete patient details or where the patient hasn't completed the test properly, that's running at about 6.5%. So on to the next slide, and I think this is where I hand over to Mary.
Okay, hello everybody. So this next slide is the alarming slide, because it shows the worrying picture in Aneurin Bevan of escalating referrals and certainly not consistently improving conversion rates for cancer. You know, it was always hoped that FIT would hone demand safely. But what we're seeing really is that FIT on its own, without changes in approach and pathway, is not going to be able to do that. Next slide, please. I don't know if you can see this, if you can get your screen a little bit larger, but one of the questions in my mind really is what is the variation in how FIT is used in general practice? You know, what is actually happening there, you know, on the ground? You know, we're having all these discussions about how to optimally use FIT, but what are GPs doing with it? So this is a work in progress. So far, 2 practice audits are complete in terms of the use of FIT, and we looked at all findable FIT use up until the end of March 21, because I needed a year to see what happened to those patients subsequently. So I went into 2 practices. One was a fairly affluent area and a small practice of 4,700 with low deprivation, low ethnic diversity. And the other one was a large practice in an area of high deprivation, again with low ethnic diversity. And immediately apparent is very different systems or even lack of systems in place. So in the first practice, they had a contact sheet where they put down every FIT issued and also wrote in the date that it was returned. And that was the responsibility of a nurse. In the second practice, there was no system in place for recording, and that made it very difficult for the practice to audit, because they couldn't do a search. That, you know, there's no consistent read coding either. So we relied on the lab return rate, and that meant that we couldn't identify the completion rate by patients in that practice. In the first practice, the completion rate is much higher than in certainly looking at our overall figures, looking about an 85% return rate. And looking at the published literature, you're looking at between sort of 49 and 98% return rate variance. And one of the key questions in my mind is, how do we change that to becoming a much more consistent return rate across the populations? When we looked at the next thing I was concerned about was, you know, are people presenting to have FIT in the same way across the board? You know, what's the difference in terms of demographics? And what was really apparent is in that small affluent practice, there were 3 times as many FIT kits being issued to patients, or certainly completed by patients, and that worries me as a big question for Wales. You know, how do we get, you can see that the male representation in FIT is much less than female, and that representation in deprived areas is much less. And I certainly will go on to do more work in terms of looking at different practices and looking at the patterns and what are the factors that seem to get that completion rate up to the 96.5, which is where you'd want it to be, really, against those practices that, you know, don't have systems or have very low return rates. And my impression from looking at the data was not that the GPs in practice B were less likely to offer it. In some ways, I'd say quite the opposite, that FIT was offered on presentation 1 or 2, you know, the review appointment, and never more appointments than that. So there was a willingness to use FIT amongst the ones that were completed. But whether there is a difficulty with presentation in those practices, or whether there is a significant non-completion rate, remains to be identified. So the positivity rates are sort of broadly, and the sample sizes are so small that you can't really read into it, but not way apart from what's happening in Wales overall. And the conversion rates, again, you know, there was a cancer found in both small samples, so really flagging the usefulness of FIT in identifying those at risk. They had different systems in the different practice for how they gave the FIT kit out. So in practice A, it was the practice of some doctors to tell the patient to make an appointment for bloods and height and weight and blood pressure with a healthcare assistant or a practice nurse, and it would be at that point they'd be given the FIT kit. But that could lead to delays of up to 25 days for an appointment. So, and that was an outlier, you know, it was much less on average. But the other practice, all doctors' rooms had FIT kits there and would give them out immediately. But that fell down with the doctors that consulted remotely, and then it became an administrative task to issue the kit. And so that practice had an issue with non-completed forms. So there's definitely a need to improve that and get some consistency across the board. But if the giving out of the kits by hand with practices can lead to that improved return rate, you know, does that personal explanation and affirmation of the importance of it make the difference in the return rate, is something that I would really like to answer. And again, sample size is too small for this to be meaningful, but there were no FIT negative colorectal cancers found in this group. Next slide, please. So the other question on my mind is what happened to the patients that are FIT negative? What's the behaviour of the GPs? And again, I kept the practices separate because I do feel there's variation in practice, and I expect I will see more and more variation in practice the more practices I go into. And so you can see in practice A, half of them, even though they met NG12 guidance, were managed within practice without referral when they were FIT negative, whereas much less, you know, so you see a much higher likelihood of them being on a USC pathway, even if they're FIT negative. And I have to say, overwhelmingly, most of these referrals were done prior to the FIT result. And I think as we go to the future, we need to be looking at the FIT results coming in first, it being part of your early decision making and about how to assess and manage the patient rather than having it alongside the USC referral. I think that would be of much greater benefit to the patient and the pathway. So we do use FIT for the RDC pathway, and of the ones, the only ones referred that didn't meet NG criteria, the only ones referred as a USC were actually to the RDC pathway instead. The last sort of bit that I want to talk about really is the reasons for FIT in practice, and we're having these big discussions about who should we allow the criteria for FIT to be used on, and you know the big discussion about rectal bleeding and iron deficiency anemia particularly. And this data is obviously pre-April 21. The big meta-analysis by Saw et al. Didn't come out until December, but it's clear that GPs are using it for iron deficiency anemia and rectal bleeding, and there won't have been anything to tick on the form for that. That would have to have been free text or not disclosed at all. But what that's saying to me is that when we're looking to modify the pathway and make sure it's clear and consistent, I think there's a willingness amongst GPs to widen its adoption. I think there's a willingness amongst GPs with appropriate guidance on safety netting to manage more patients in primary care without that referral. So this is a work in progress. We can just go to the next slide, which is the last slide from me, and then on to Rodri. So I feel the key issues for us to nail at the primary care stage is the request form and process issues, making sure the request form is complete. Are we doing it in the right way, having the paper request form? We like having the straight to test service. You know, that form has enough information to make the referral, and from the point of having the positive FIT, it could be a very streamlined pathway. In fact, at the moment, the colorectal nurse team are very, very stretched, and it's not that streamlined because they haven't been resourced sufficiently. Or do we need to be thinking about just using GPTR as we do all other tests and you know, FIT as the test and refer in? It was very clear from the audit that I did that a lot of GPs were opting to refer alongside, and we've tried to improve that duplication of referral by adding a tick box to say, have you done a USC referral, and then Helen in the path lab doesn't have to refer on as well, but it is an issue. We've definitely got to get that message across about recording the FITs issued, and I look to England on this because they now have an early diagnosis part of the GP contract, and that includes a DES, so direct enhanced service for improving the system of FIT, which looks to have a target return rate of 80%, and we haven't adopted that kind of early diagnosis into the GP contract at the moment, and I really think we need to consider that just so that we get the systems in place. And we need the standard operating procedures for FITs that aren't completed, you know, practice responsibility and what to do if they are, and to have that discussion. There is no read code for a FIT result, which makes audit in practice, if you're going to rely on that, quite difficult. And it would be nice to see our colleagues in DHCW address that for us. And I'm really concerned about the unequal access and uptake across the demographics of the populations. And, you know, we know that men are more likely to die from colorectal cancer. And yeah, we've seen the presentation, you know, for FIT tests is less. So we do need to look at deprivation, ethnicity, potentially. I haven't looked at that yet, but also gender in terms of access to FIT testing. And Rodri will also highlight the need for safety netting, as everyone else has this afternoon. So I'm going to hand over to Rodri now to finish us off.
Thanks, Mary, and good afternoon, everyone. Yeah, just some issues from secondary care. If we can go to the next slide, please. I don't want to repeat what Kath and Mary have already said about the service in Aneurin, Bevan. We have familiarity with FIT for about 3 years now, which initially started as our FIT pilot. Interestingly, I think the outcome of the FIT pilot was very similar to the pilot results that have been reported from Cwmtaf and Cardiff and Vale already this afternoon. We also did the USC project during COVID-19, which was published in British Journal of Surgery. And on the back of the pilot study, established a nurse-led straight-to-test service for the FIT positive service, currently led by Michelle Warwood, who may be on the call. Now, the whole ethos of this was having a single point of referral, using FIT triage in primary care. And I think some of the challenges that we've encountered have been related to the pathways, when and how to refer. And I very much welcome the news that the BSG and ACP are developing a clear guideline for this. And I think that would be fantastic that people are sort of using the same sort of criteria across the patch. And as has already been discussed, is having a clear policy for safety netting for patients who are FIT negative and not referred initially through to the straight-to-test service. We have, of course, patients with colorectal symptoms, iron deficiency, anemia, change in bowel habit, are referred either to gastroenterology or to surgery. And the ownership of this service has been an issue for us, and developing business cases, getting a properly funded service for the FIT tests, which is still being funded by scheduled care, unscheduled care, the specialist nurses, which have been managed currently by scheduled care, and the clerical and admin support. And I think this does require some engagement from executive teams to develop properly funded service so this can be properly delivered. And of course, it needs colonoscopy capacity, quality assured colonoscopy capacity to deliver the colonoscopy that we need for the positive FITs. How patients are coming through there, are they sort of just sent back to primary care if they have negative investigation, or do they need referral on MDTs, IBD services, etc., etc. So all of these have been issues for us, and I think it is very much work in progress. So thank you.
So I'll ask some of the colleagues who've spoken, and Dana, my colleague, to kindly continue and chair the panel. Thanks, Dana.
That's great, thank you. Yeah, as our panel members join us, I think we've got a great few, as you can see. I'm not sure, really kindly, Kevin has offered to hopefully join us during his list or after he's finished his list. I'm not sure if he's got to us yet, but in the interest of time then, I think there was obviously very interesting conversations right at the front, and Sunil obviously put a question to Michael really, but obviously all the panel can think about it. The use of sub-thresholds of FIT to manage and decide, and can I ask sort of panel members really what their thoughts are on that?
Yeah, I mean, I'd be interested to see. I know there are, Mike, you're right, there are some trusts in England also implementing a similar situation where in between the above 10 threshold, there are some arbitrary thresholds where you say below 100 we'll do this, or between 100 and 200 we'll do that. And I just wonder how the follow-up is going, because knowing how much false negative we worry about with even the lower threshold, have you had much experience of what kind of pathology you're encountering in these different groups?
With regards to the different thresholds, to it's very difficult to say. Seeing, you know, I haven't got the data to say we're seeing different types of pathology. Certainly, very high thresholds in the hundreds. You know, it's more often than not a cancer, but then we're also seeing cancers in patients with, you know, very low FITs, you know, between 10 and 50. So it's a difficult one. The challenging ones, I think, are those who clinically, you know, you strongly suspect's got benign pathology, but the FITs are high, and then what you do with them when the colonoscopy's negative. And I think, you know, I'm certainly starting to get a feel for those patients who are likely to have false positives, and maybe being, you know, adjusting our approach to those ones. I'm finding particularly patients with high alcohol intake and parenchymal liver disease often seem to have false positive FIT, and you know, these patients are quite difficult. But I haven't got any other data to go on, Sunil. I think certainly from conversations with colleagues in NHS trusts in England who I've kept in regular correspondence with as we've reviewed our pathway, it's certainly evident that even before COVID, some NHS trusts who were already utilising FIT were already in the process of adjusting their cut-offs. So, for example, patients with normal bloods, some trusts were raising thresholds to the lower threshold to 20, even raising threshold up to 100 for those patients with benign symptoms who are below the age of 40. So I think that, you know, individual NHS trusts have the right to adjust their entry criteria to their 2-week pathways, their colorectal pathways. But a lot of that's been done, you know, with local agreements based on their experiences and, I guess, resources and things like that. It's very difficult to advocate that in the absence of evidence base there.
I think my observation or wish would be that there could be some further work in terms of comorbidity and potential impact on likely positivity, particularly thinking about anticoagulant use or inflammatory conditions that might alter the likelihood of or the volume of blood into the gut, which I think is the thing. You know, you get a strongly positive, and it may be that it's and that's what I'm seeing in the RDC. Quite often you can get some low positives with people on anticoagulants, and it would be lovely to see that clarified, and as just, or even just some guidance for clinicians on triaging that. You know, just do they need to go in with a colonoscopy straight away with that, or is there a need to have a more considered approach, given the risks of taking them off an anticoagulation for the test, for example?
That's great, thank you. And I don't think Kevin's been able to join us yet, but obviously we've had good discussions around rectal examination, and I just wondered some thoughts on that, please, from the panel.
So it was just interesting that in an era where we seem to be doing more and more virtual clinics, and if we look at the FIT negative cancers, how many of those were actually rectal? It is worrying, and certainly when I talk to secondary care colleagues in colorectal surgery, I think we agree on the fact that rectal examination seems to be not carried out in the patients where it should in all these referrals. And I don't know if people have any thoughts around that as to how we can emphasize that perhaps in all settings.
I think this would come back to, you know, if we had a single point of access, then, you know, basically we would have preset criteria that would have to be applied for patients to enter the system. And I think that, you know, certainly from the available data, it's quite clear that on the FIT studies that have been performed so far, the very few false negative FIT detected cancers, you know, would have been identified if account had been made of rectal findings or iron deficiency anemia. And that's why, so again, important just emphasises the fact that FIT isn't an isolated test. It's not the panacea. It needs to be taken in context of other clinical findings. If you combine a FIT test with a rectal exam and blood count ferritin and exclude iron deficiency anemia, it becomes an incredibly powerful rule-out test. An isolated FIT alone without the clinical context, though, it's not as reliable, although it's still very good. But you know, I think that's you know, should be a basic requirement for a secondary care referral. I think if a physician is concerned enough that a patient needs to go and undergo possibly invasive investigation, I think as a minimum they ought to be doing a rectal exam. It makes a big difference in prioritisation.
Thank you, Michael. And did Raji pop your hand up? Did you want to come back in?
Yeah, just a comment really. We're in the Cardiff and Vale pilot, we had included rectal examination and a bunch of options, whether it was a virtual consult or whether it was not possible, yes or no, etc. And I just wonder, we've centrally captured that data, and I just wonder whether, again, bringing in that coordinator's role where you can filter out patients who have had a virtual consultation or haven't had a rectal examination, whether an automatic letter can then go back to the GP to say, can you please provide this information? And again, it's about centralization of data and what information is actually put in. One thing I didn't mention in the talk was of all the 7 patients who developed cancer in the FIT positive rectal bleeding group, all of them were left-sided cancers. So there were 5 rectal cancers and 2 sigmoid cancers. So pretty good pickup rate with flexible. I mean, it would have been reasonable to do a flexible sigmoidoscopy in that group.
Thanks very much, Raji. Did Mary or Ruth want to reflect on that? Because obviously sat in primary care, we understand the challenges faced, and if there was any sort of, you know, is it a reluctance on patients sometimes, I think?
I think there is sometimes a consent issue. Some of them feel that wouldn't put their mind at rest sufficiently. I suppose that's then thinking that it would be an in or out test, like literally. But I do think in this era, particularly in the one practice where they had doctors who routinely consulted remotely, that becomes an issue. So if an administrator ends up completing the form for them, you're not going to get that clinical examination that's needed. And certainly that was the feedback from the audit to that practice, that, you know, that this test should be accompanied by clinical examination, and that they have to find a way around that. So, albeit that they might have to book in a doctor that is there sitting face to face, but that is what needs to happen for the patient and their safety. And but it's getting clear messages across, and I've not long since done the Red Whale Cancer Update for GPs, which is a very, very good course, but they were not plugging the need to see and examine patients. And they were saying that they could see validity in some instances of not needing to see and examine a patient for a USC pathway. And so as that was a free course provided to the GPs in my area, that's where they're getting their information from. And, you know, it's just that lack of consistency of message going out to GPs, I think.
Yeah. I think even when patients do come in and they're seen face to face, and GPs are facing quite a lot of patients waiting in the waiting room, and there's a lot of time pressure on them, that sometimes people take into consideration, is this going to change my management? And I think that sometimes, while they may sort of put a hand on the tummy, sort of to feel for a mass, getting the patient sort of ready for the PR and doing the PR for them and the consent, and if they're really rushed and they feel if it's normal, I'm still going to refer as USC, and I'm referring as USC anyway, so it's not going to change the plan, then they may not complete a PR examination as part of it, even though I appreciate in secondary care that if they did feel something on PR, then it may prioritise them on your USC list. But sometimes it does come down to how is the time versus how is it going to affect the management of the patient.
That's really helpful context and great, obviously, to understand what we're all faced with, really. I'm conscious of time, but obviously there is a couple more questions in the chat bar that would be interesting, seeing we have such experts within the group to pick up. I don't think Kevin's been able to join us, unfortunately, but what's your feeling on whether or not we address maybe Sunil's last question about sample receipt times and tracking and centralised system versus practice-based? Any thoughts on that as one of the final discussion points? Sunil?
Yeah, I do think this would be really interesting to look at, because UK-wide, this is genuinely an area people are looking to see what works. Does keeping the kids at on-site in the surgery work better? Can we track them better? And Mary, you alluded to some of the things that you're trying to emphasize in terms of recording whether someone's received a kit or not. It'd just be very interesting to compare how those two systems work in terms of tracking, and are we more or less likely to miss any patients if we are not doing that tracking. So I don't know if anyone's got any thoughts on that.
And I just want to say beforehand that John, Geen and Catherine and that, I believe their mics are on, although their cameras are on, so they can also chip into this conversation as well. So
I think it's a really difficult area for primary care. I think safety netting hasn't had the emphasis that it is needed in kind of policy and direction. So I think it's finding our way. But when you have the emergence of pre-tests, and FIT will only be the first of many, we become more reliant, and the safety netting will become absolutely crucial to running safe systems. So we need to do it. And so CumTAF and Aneurin Bevan are trialling See the Signs, which has the safety netting dashboard for FIT, where you could literally put in that you've done a FIT, and then you will get updated searches of whether it's returned or not. So we need to evaluate whether that is useful and adopted. But of course, even on the contact sheets, you're relying on someone putting it on a contact sheet, and so I can't say 100% that that's reliable. Your system, where they have to put it online and it gets sent out, is the only way, so they don't get a test unless they have it. But I do think there are disadvantages of that system, and I don't know it for sure yet, but I do suspect that personal touch of giving the patient the kit, it certainly takes off a couple of days of turnaround time compared to when they weren't giving it themselves, when they're giving it to other people to do. It certainly takes off time there, but it may actually be better for patients to have it from a familiar face that they trust.
I think it'd be good to actually see that. It'd be really interesting to see some data comparing the two approaches, and I'm sure it would inform everyone across the UK on what might be a good way to go about it. Thank you.
Would Gareth, would you have any thoughts on that? Because obviously you're dealing with lots of samples and coming in via that, and the return rates are great. Do you ever get sort of some patient feedback?
To be honest, we haven't. We're sort of fairly confident that our return rates are kind of in the area they need to be. And I suppose for the clinician, it's the quality of the counselling they give to the patient before they make the online referral. I totally appreciate that. Yes, the clinician handing the test to the patient probably does have more impact than just saying you will receive something in the post. And we did look at different models, but we've taken a lot of experiences from the bowel screening program and kind of used existing mechanisms and existing processes that were in place to distribute the kits. So when we did look at it, even for relatively small volumes of testing, it quickly becomes very difficult to manage by itself. It's a whole new aspect to the service we'd have to do around the coordination and distribution of kits, around ensuring that all the kits within the GP practice remain within their expiry dates. So you have a whole stock management aspect that's kind of evolved down to the GPs. So on a practical level, that would have made it harder for us. And then when we looked into the costings of distribution and this management as well, of course, that kind of was fairly substantial. So we did look at kind of the two models, and we felt that the screener model that we were essentially latching onto was probably the one that would suit our model of service better. But yeah, I can totally appreciate that for some patients especially, I think that one-to-one interaction as they're being given the kit probably would help, and may even reduce those ones who are the non-responders if they did have that interaction. It's just applying that on a large scale, really.
Yeah, I mean, I just describe what our process is. So we get a sealed envelope from the lab, and inside that envelope you've got your patient information leaflet, the request form. So the GP has to open it, or whoever is doing it has to open the envelope with the patient in order to complete the request form. And then you've got your kit in there and everything else that's needed. And so by taking it out of the thing and talking through the request form and showing them each item and having that interaction, it is, you know, it's time consuming, and I think that's why some of my colleagues would pass it on to a nurse or a healthcare assistant to complete it. But you certainly get that sense from the patient as to whether they're going to be able to do it or not.
It's certainly an interesting debate, and I can see Kevin's joined us. Thank you so much. You've been very busy this afternoon, Kevin, with your list, so really appreciate you joining. You just entered on the debate of whether or not you know, kits should be sent out centrally to patients or sit within primary care and be distributed by the primary care practitioners or teams. I suppose across England and the UK, you have that debate and probably have a different model even across England.
Yeah, I think one of the things that's perhaps been lacking is in the absence of a guideline, it's difficult for commissioners to develop services. So I think that having you know, even a very simple guideline allows people to start thinking about what they need in order to be able to deliver this, because where there are lots of options, perhaps doesn't necessarily happen very efficiently, or where there's a secondary care model next door to a primary care model, I think actually can create a lot of variation. So you know, I think with our guideline, I think we've gone for a primary care requesting the FIT test locally, but that relies on primary care having access to FIT kits, and perhaps those FIT kits should be available in every pharmacy, and you know, should be made easily available to primary care in order to facilitate that interaction.
Thanks, Kevin. I think that's, and thank you for your talk as well. It was really very comprehensive and good to hear what's happening at the national level. I guess what we've done, and we were just discussing this perhaps just as you joined, was we've got two health boards having slightly different approaches, but there are pros and cons to each one. We've had a centralized approach, which makes it perhaps in some ways easier to track who's returned their sample or not and send reminder letters. On the other hand, there is a very manual, labor-intensive process that I think Kath has put in the chat bar as well, where you really need someone to keep solid track of which surgeries are requesting how many kits, whether they're over requesting, whether they're over calling. So I guess that is certainly a logistical issue to perhaps shed some light on what might work best so that we don't lose patients in the system somewhere.
In England at the moment, GPs are being incentivized to ensure that when they refer patients, they have requested a FIT test. And so they're kind of disseminating the responsibility rather than managing it centrally, but kind of rewarding good practice. And that's something that NHS England are doing presently. But yeah, I don't know if that's answered your question.
I can see it's created a lot of conversation now in the chat that's been a bit quiet, and I think it's important that these conversations are continued, and we obviously want to facilitate that in the NEP. So any questions that come up or in the conversation today or even after the event, then please get in touch with us. I'm Naomi, I can see your hands up. I'm conscious of time and how we probably need to draw things in a bit. Was it something that you wanted to contribute?
It was just a really brief point, just kind of picking up on what Kevin actually mentioned about like agreeing some principles then and standards. So rather than sort of pitching maybe against the centralised system, against, you know, Aneurin Bevan's model, rather than doing saying one or the other is better, we need to agree standards that we should be aiming for, regardless of which model we go for. It's a thought.
I think.
Sorry, Sanil.
No, I would agree with that. I think that's sensible. It's not really a question of micromanaging a system. It is really about, is it able to deliver what we really want.
Yeah. Okay.
My point I was going to just say is copying what NHS England are doing and getting that early diagnosis work into contract for GPs and actually really flagging it and making sure it's a priority in practices to build the systems.
And it would be great just to give some key messages out. So Naomi, Sarah, if you were happy to just share your slides on what we've summarised for today and maybe pick up some next steps.
That's great, thank you. So to recap on what we know so far then and what we've discussed today, and as the presentations have shown, Symptomatic FIT has been rolled out extensively across Wales over the course of the last few years. So as Dana's presentation at the beginning of this afternoon showed then, the progress from, you know, that has brought us up to where we are now. And so the stage we're at now, where we're able to have these really helpful in-depth discussions and reflections on how it's working in practice. We're obviously pleased to be able to report that it's now available in all Welsh health boards, which is testament to the hard work and commitment of our colleagues across Wales. COVID has obviously had an impact, and it has acted in particular as a catalyst for implementation, particularly for use as a triage tool in suspected cancer referrals. And as Dana mentioned as well at the beginning, the NEP published a FIT framework for implementation for Welsh health boards of FIT in the symptomatic service in 2021. So now we're talking about a final push that's needed then to maximise accessibility and uptake for symptomatic FIT for both DG30 and NG12 patient cohorts across all health boards in primary care and secondary care. And the NEP will continue to support with this. It is also acknowledged that there is an emerging evidence base. And I'll hand over to Sarah.
We're able to move to the next slide, please, Adam. Thank you. So just some take-home messages then. So clearly from today's presentation and the work we as a National Endoscopy Programme are undertaking with services across Wales, there's clearly a huge amount of learning across the country that can be shared. As Naomi's mentioned, the adoption levels are different, but there's a huge amount of learning that can be taken away for implementation. It appears there seems to be an appetite for standardisation of safety netting principles across Wales, so to mitigate variation in patient care, avoid any sort of confusion between primary and secondary care, which leads to the third point around the importance of strong communication and sort of education across primary and secondary care, so that there's consistency with language and processes, and that's really important both for patients and for leads and colleagues within the services. We heard from Raji, and I think it's sort of teased out of a few of the presentations today about the importance of appropriate admin and nursing infrastructure for the service. So we've heard about areas that have got FIT coordinators or FIT nurses. So the FIT coordinator role we've heard is quite key to, or I say quite, very key to support FIT test requesting, tracking of requests, patient returns, managing input of data, and then the FIT nurse role to support triaging, make sure there's a robust process for validation. Clearly really important that there's a point of contact for patients depending on the results and outcomes of those FIT tests. And lastly, also making sure that there's appropriate process to manage follow-up and sort of onward processes post FIT outcomes. And last two key messages then. So I think generally for all our systems in the NHS, but really important to this sort of FIT pathway is the importance of IT systems to enable what we're trying to implement, so that we're not wasting time with manual data entry and input of information, that requests or results aren't going missing because things are done via paper format. Just really important that there's an IT system to support all of this. And lastly then, which I think is a nice message to end on, today has clearly been a learning event, and it's clear that it's really important that there's a continued process for the gathering, monitoring and evaluation of data across all our services who are implementing FIT. Learning from services who are operating in the same fashion is really important, so that services who are perhaps not quite up to the same level can learn from experiences and overcome constraints or challenges. And I think through the support, as Naomi said, of us within the National Endoscopy Programme, we really want to support that shared learning. So if after today you want to be put in contact with other services who perhaps haven't been on the call to link yourselves together, then please do that. But I'm going to hand over to Dana and Sunil now, who are just going to sort of bring the session today to a close. So thank you very much.
Thank you, Sarah. May we have the next slide, please, Adam? Dana, would you like to kick us off?
Yeah, and basically, like I said, I think, you know, Sarah's and Naomi have reiterated, you know, there is a massive learning from today, and obviously we want to share that learning. So to start off, we'll obviously have today's presentations. We've got the recorded event. We've allowed people to register even if they couldn't attend to dip in. And actually every presentation that's been given has been recorded separately. So we're very happy to disseminate to health boards on our own websites and to HIW in order to support further learning. I think it would be really great that you know, we've made links with Kevin and UK teams, and I think it would be great to continue those teams going forward, certainly with the development of the guidance going forward. I think, Sunil, you wanted to pick up the next point.
Yes, this was really extending Sarah's point about different health boards are in slightly different places with regard to how much implementation has happened and how much engagement has happened with their primary care colleagues or between colorectal surgery, gastroenterology. And if it helps, we can, within the National Endoscopy Programme and with our partner organizations, act as a coordination hub. I know colleagues from Single Cancer Pathway are on this call, and colleagues from Life Sciences Hub, Health Technology Wales, a lot of them have been on this call, and it would be good to have a coordinated approach for information sharing between health boards and other organizations rather than everyone having to reinvent the wheel. So template letters, all those kind of things. I think it would be good to see if there is an appetite for us to have a coordination hub for this. Do let us know if you think that would be useful as well. Dana.
Yeah, and finally, again, there was lots we've pulled out, and we'll certainly take across the messages about, you know, thoughts of standardising safety net in single point of access for GP referrals, but also the things I think clinicians struggle with and that we've been hearing is that, you know, you delivered FIT in your organisation and certainly did it probably, you know, with the hard graph without a business case and without anything in your IMTPs. So we are keen to support you in that going forward. We've certainly raised issues at our board about, you know, getting the message to execs that we need these pathways in your IMTPs and we need support and that in relation to sort of robust business cases. But again, we're happy to share learning and support all the health boards across in this area if you'd feel it would be helpful.
Thank you, Dana. I think just before we close, and I know it's a slightly unfair thing to do, but and Kevin, you very kindly only managed to come towards the end of the session, but we'll definitely be sharing the links for all the recordings and presentations with you. Is there anything particular you feel in terms of insight from how things have happened in England that you think might be helpful to share before we close for the day?
Well, just one little bit of news that you may know is that the NG12 and GD30 guidelines are undergoing consultation this month and will be extensively reviewed. I think that I think it's key that you obviously have a very coordinated system in Wales. We're very keen to work with NHS England to ensure that this is effectively implemented. And one of the ways that we have to make sure that primary care are fully on board with this. Otherwise, I don't think it's going to work. We can't impose a system in primary care from secondary care. So we need to make sure that essentially there's good team working and with our Delphi process, which was quite extensive across different specialties and across the 4 nations, we wanted to make sure that everyone feels that they have a stake in this, but also that it remains relatively simple and therefore deliverable. So yeah, I don't know if that's helpful or not, but I think key to implementation is maintaining simplicity, clear communication, and good team working.
That's absolutely true, and those are indeed very key messages. Rather than overcomplicate pathways, it is useful to know that FIT can be used really without much hesitation in almost most settings. We did discuss in between about certain settings where it's helpful to have discussion about appropriateness, individual patient circumstances, etc. But I agree, I think a coordinated approach and simplicity sounds like the way forward. Thanks very much for that. And thank you also to all of the speakers today for a really excellent session. We'll be sharing the links for all the recordings, and thanks very much for participating. Thanks all.
Thanks very much, everyone.
Thank you.